Good evening, everyone. Welcome to the webinar. Today, I will share with you the angio-aligner treatment troubleshooting. My topic today, the following topics. The first, I will talk about the assessment of fitting of aligner, how to assess the fitting of aligner. And the second topic is about frequently encountered troubles and shooting. The first, I will talk about the abnormal tooth mobility. And the second will be the undesirable tooth intrusion. And the third, off-track of tooth extruded. The fourth, poor correction of tooth rotation. The last one will be the development of posterior open bite. Okay, let's start from the first one, the assessment of fitting of aligner. In clear aligner treatment, what is a good fitting of aligner? That means there is no gap between the aligner and the incisor edge of the teeth and no space around the attachment upon the aligner insertion. So this picture shows us the good fitting of aligner. You can only see the thickness of the aligner, but there is no gap between the teeth, the edge of the teeth of aligner and the attachment are fitting very well. Let's see the poor fitting of aligner. There are different types of poor fitting of aligner. The first sign of teeth not fitting into aligner is the gap between the aligner of the incisor edge or the space here, the space around the attachment when wearing the aligners. This is a single tooth not fitting here and here, the first premolar and the canine. These are the double adjacent teeth not fitting. Here and here is posterior teeth. Sometimes there are multiple adjacent teeth not fitting, like this anterior teeth, the 6 anterior teeth, they are not fitting, and here the posterior teeth, and also lower incisor edge, lower incisor teeth not fitting. It's a poor fitting of aligner of multiple teeth. The aligner not fitting is a performance of discrepancy between the tooth positions, including attachment in the aligner and intraorally. Okay, we need to find out the reasons or troubles that may lead to the poor fitting of aligner and deliver a solution. So let's go to the frequently encountered troubles and how to shoot them. The first frequently encountered trouble is the abnormal tooth mobility. This trouble was usually accompanied by poor fitting of aligner. So let's see the probable causes that lead to abnormal tooth mobility. The first one is the force on the tooth or on the teeth was too heavy. And the second, the occlusal interference was present. Let's see one by one. Let's see the first one. The force on the teeth was too heavy. This occurs when there is a non-compliance and the patient is changing aligner when the tooth movement has not been given time to express fully. The orthodontic force accumulated in the new aligner, and overuse of a choice was dangerous for the patient. And in this case, in this situation, the excessive force may be applied on the tooth and may cause abnormal loss of tooth. So the patient's compliance education should be continued throughout the whole treatment process. If the aligner does not fit due to a lag between tooth movement and the aligner, we can consider dropping back in aligners. You may review the ISO setup and find the stage that most closely resembles the intraoral position of the teeth and try the aligner that best fit the arrangement of the teeth intraorally and retain for a period of time if the tooth mobility larger than 2 degrees and back up to the current aligner. In this kind of situation, monitor the patient closely until the treatment is back on track again. If you cannot get an aligner that best fits the arrangement of the teeth intraorally, you may submit a reboot, and we can design a new ISO treatment plan. Another cause that may give rise to abnormal tooth mobility is the occlusal interference. Let me show you a simple case to explain it. This is a simple case you can see. It's a mild crowding in upper and lower arch. These two, the teeth 22 and 32 crossbite. The treatment goal was alignment and corrected the crossbite. So it's an easy case. So let's see the ISO setup. It seems nothing special. We align the teeth, align the arch by IPR. Altogether, 31 stages. But at stage 11, the patient complained that these two teeth were loosened and sensitive to cold and heat stimuli. Clinical examination showed that these two teeth was 2 degrees loosened, and there were occlusal interferences existed. How does it happen? By review the ISO setup, we found that the tooth 22, this tooth, kept labial and the derotation movement slowly, very slowly from step 6 to the end of the treatment stage 31. In the whole process, with this tooth move, in the whole process, there were no occlusal pad designed to open bite. So the cross-bite correction lasts a long time, and the occlusal interferences persist. That's why these two teeth were loosened. You can see from here, the cross-bite was not corrected for a long time. In this case, we had to reboot because only by reboot we can solve this problem. So we have to reboot and start a mid-course correction. This was the ISO mid-course setup. we can see, let's see what's the difference. This time, IPR still was designed, and the tooth 22 moved. And the timing, we improved the timing of cross-bite correction. Let's see from this view. First, we intrude the tooth 22 first, and then move it labially. You can see the tooth 22 from the stage 6 to stage 17, and the lower teeth 32 moved from stage 9 and move lingually simultaneously with the tooth 22 moving labially. So the occlusal interference during the treatment was minimized. So the solution for this kind of occlusion interferences during the treatment is a setup, also setup management. We should coordinate. When in the IOSO design stage, we should coordinate the movement of the upper and lower teeth in the IOSO design phase. This is very important. The crossbite should be corrected as soon as possible. If we have enough to create enough space for the teeth to move, we should move it as fast as possible. This is a post-treatment result. Okay, let's see another case. We can see a rotation of upper central incisor and crowding, and the tooth 11 and 41 edge-to-edge occlusion. This is an extraction case. I extract 4 first premolar. Let's see the IOSO setup. This kind of case takes need more aligners to correct. So extraction case is a difficult one of the most difficult cases by clear aligner. Let's see the progress. These are the mid-treatment picture. We can see there are with the derotation of the 11, the tooth 11, and the retraction of the lower incisors, the upper and lower incisor occlusal interferences developed here. And the patient complained the teeth 11, 21, and 31, 41 were loosened. And we found that there are premature contact of incisors and the open bite in the posterior teeth. These were the intraoral photos wearing aligners. We can see that the occlusal interference were relieved while wearing the aligners. And as we know that this interference is a temporary occlusal interference, so no grounding needed. What did I do in this case? And I encourage the patient wearing aligners all day long, only except for brushing. It must be emphasized here that oral and aligner hygiene maintain are particularly important in this way. And I stopped changing upper aligner, waiting, maintain and waiting, and retain with the current aligner, and the lower aligner proceeded as usual until the occlusal interference was relieved in natural occlusion. You can see the occlusion became better and better. No open bite in the posterior teeth. This intro review after treatment. So this case, we can see we don't have to reboot by encouraging the patient wearing a liner all day long except for brushing. And I adjust the pace of upper and lower aligner changing and solve this problem. Let me make a summary for the solution of the occlusal interferences during treatment. The first one, I also set up management. And the second, adjust the pace of upper and lower aligner changing. And one more, encourage the patient wearing a liner when eating all day long, except for brushing teeth. So this is a summary, a table for you to easy to understand and remember the trouble, the cause, and the solution. Okay, we come to the second trouble is undesirable tooth intrusion. The common cause of undesirable intrusion is lack of space. As we know that the force plus space makes movement. If a tooth has a force placed on it, but insufficient space to bring it into the arch, it will not move. And similarly, if there is sufficient space but no force engaged on the tooth, it will not move either. So teeth require both force and space to move, and teeth cannot collide into others to reach the position in reality. So let me take some cases as examples. This is an easy case with mild crowding here, upper and lower incisor crowding. The molar relationship is normal. This is I also set up to create space by expansion and IPR. It seems a simple case, nothing special. Altogether, 25 stages. Let's see from this view. The vertical position of this teeth, of this canine, you can see was maintained, not changed. From this view, we can see by IPR, create space by IPR, and the canine is lingually translation and aligned. The patient wore all the 25 aligners and come back to the doctor and found that the tooth, this canine, was intruded unanticipatedly due to the lack of space. So in this case, we had to reboot and start mid-course correction because we don't have enough space to correct the introversion of these teeth. So this is a mid-course setup. You can see IPR here to create space for the canine. And let's see from this view, maybe it's clear. Okay, we have attachment and extrusion, create space, and then extrude. IPR here, and we create space for the canine. The attachment is a special attachment. It's a inverted day rotation attachment was designed on the canine for extruding while they rotating. There is a step here. You can get the attachment. There is a step here, and the gingival side of the attachment for the extrusion of the teeth while rotating. So this is after a period of time, the canine was extruded and aligned. Another case, this is with a case with crowding and deep overbite. Also an easy case, alignment, let's see the setup. Alignment to create space by IPR and intrusion of anterior teeth. Now together 25 stages. This patient also worn all the aligners and come back and see that the teeth, this teeth, yeah, was introversion. How did it happen? This is the before treatment. This is I also design final position, and this is the clinical result. We found out that we can be sure that the teeth was intruded, and we found that the IPR was insufficient. We have IPR designed here. So space is not enough. So the case was also rebooted and started a mid-course correction with more IPR here to create space for the teeth 21 and the beveled, and we also designed a beveled attachment on this teeth. Let's see the treatment plan, the virtual treatment plan. This attachment was designed to extrude the teeth 21. Okay. Let me make a summary for the solution of undesirable tooth intrusion. First of all, the IOSO management is very important. In the IOSO treatment plan stage, it's very important for the treatment plan. So the doctor should ask the technician to make sure that there are open contact. That means no collisions, mesial and distal to any rotated or lingually erupted teeth before moving the teeth. To create space first before moving it into alignment. The second is the clinical monitoring. This is one of the most important aspects. The contact mesial and distal to the teeth rotated and or should be checked with dental floss at every appointment. So I think the dental floss is a very important tool for us treating patients with clear aligner. I will use dental floss and every visit to examine all the contact relation of every teeth to make sure the teeth moved have a loose contact for them. It's easy for them to move to the position that we designed. If the contact are found to be tight, I will strip lightly with sandpaper to make sure the teeth have some space, a minor space to move, even if there is no IPR was requested. If the patient comes to you with a severe tooth intrusion, the rebooting and the starting mid-course correction was necessary. So sometimes reboot is we have to reboot in some case. So this is also a summary in table for the undesired tooth intrusion, the cause, and the solution. The third trouble is off track of tooth extruded. Let's see the cause of this trouble. Lack of space first. The second is the tooth extrusion movement too fast in the ISO design. And the third is the attachment not designed or not bounded. For lack of space, for the solution, we have to create space. We can IPR, use sandpaper or rotor IPR tools to create space for the movement of the teeth. And for some cases we can use biting chewies. It's only for the mild off track. For example, only the gap between the edge of the aligner less than 0.5 millimeter. If there are large gap between the teeth edge of aligner, the only biting on chewies cannot solve the problem, cannot get the tooth back. And the third, we have to use some elastics to get the teeth back on track. For elastic, the bootstrap elastics is usually used for this teeth. For example, you can see this is a plastic model. A bootstrap elastic can be used in those cases where you don't have to stop and order additional aligners. Since the remaining teeth, the other teeth are tracking well. So you can make a cutout on the lingual gingiva and label gingiva accept of the aligner and bound a clear button on the lingual and label side of the teeth and use a 16-inch and 3.5 ounce elastic from label button and over the edge to the lingual button, just like this. The elastic places the force to the tooth, which extrudes it back into the aligner. We make sure that there are the contact mesodistal of these teeth are loose. They have very mild space for the tooth to extrude. For long clinical crown tooth, you can deal with this problem like this. You can bound a clear button and the edge, besides the edge of the aligner, and a clear button on the teeth, on the gingival accept of the teeth, and use elastic like this. button-to-button elastic. This case, this tooth of track while extruding and moving mesally. You can see a gap, a large gap between the teeth edge and the aligner. Clear button bounded on the buccal gingival aspect of the tooth and the label cusp of the aligner, and have the patient here on the canine and have the patient attach elastic like this to assist the tooth 22 back on track again. So the direction is very important for the doctor to decide how to the direction, how to add the button on which place, on the aligner, on which location. For the short clinical crown teeth like this, the extrusion is not enough. So, and you can make a cutout on the label gingival aspect of the aligner here, and the clear button bounded on the label gingival aspect of the tooth, the attachment, and then also attach elastic to the button on the teeth of the opposite jaw. For this case, there is a button on the opposite jaw canine, and the elastic like this. So the force can be delivered, can be added on this teeth to extrude. It's after treatment. And also like this, the upper lateral incisor, we need to extrude these two teeth so we can have a elastic like this. And the second cause, if the extrusion movement was too fast, that means more than 1.2 millimeter per stage, the tooth may take the risk of tracking. You can see the movement step in tooth movement data in ISO. So if the tooth moves too fast, more than 1.2 millimeter, you can ask the technician to slow down the movement of the teeth. So the solution for this case should be extrusion movement should less than 0.2 millimeter per stage. As we know that attachment is prerequisite for extrusion movement. In the ISO design stage, be sure that the attachment was placed on the tooth extruded. And remember, bound the attachment once the tooth starts extruding. If the tooth off track, we need auxiliary elastic will be used to get the tooth back on track. So for the solution of this problem, first, the ISO design management is very important. Don't forget to add attachment on the tooth that need to be extruded. And don't forget to bound the attachment when it starts to move to extruding. And if the off track happened, we can use auxiliary elastics, just we mentioned before, to get the tooth back on track again. So this is also the summary in the table. Okay, we come to the fourth frequent encounter troubles is the poor correction of tooth rotation. Let's see the cause of poor correction of tooth rotation. The first one is lack of space. The second is the off track of an aligner. How to deal with this problem? I will discuss these two causes together. In ISO software design stage, ask the technician to make sure that there are open contact. That means no collisions between the mesial and distal to any rotated tooth to allow the rotation to correct freely. And restaging the tooth movement to create space first before moving it into alignment. And so we can make this tooth movement more clinically predictable. And always lightly stripping contact mesial and distal to the rotated teeth with sandpaper to make sure the teeth have space to move, even if we don't design IPR. And the second, you can use the dimple plier. Yeah, there are many different pliers of different type of dimples. So this is one of a plier can form a rectangular dimple on the teeth for the teeth to give a pressure on the rotated teeth and help assist the rotation of the teeth. And also we can bound a bump just like this. There are some anterior teeth rotation that won't respond to the deepening of the aligners. If you are certain that the interproximal contact are loose, there are space for the tooth to move, for the tooth to rotate. It may be that the dimple created in the aligner does not create sufficient force to achieve the desired rotation. In these cases, we can try bonding a bump here. A bump is small, it's about 0.5 millimeter thick dome of attachment material on the surface of the tooth requiring additional force. For example, like this one, the tooth 11 requires additional mesial in movement, rotation, and we bound a resin here, small composite bump here on the mesial aspect of the labral surface of the tooth, and have the patient insert the aligner and adjust the height of the bump so that the patient feels there are pressure on the tooth, not too big, not too large, not too heavy, and have the patient return to the clinic 1 or 2 weeks and check for progress. This technique is very effective to achieve the last few degrees of rotation, and helps the rotation, minor rotation, reduce, and also can reduce the number of refinement and shorten the whole treatment time. The fourth solution is rotation ridge. Andy Tian developed a rotation ridge feature for incisor derotation. You can ask the technician to add this feature and the last 3 stages of staging. It's like this. Here also the T is 11. It need a meso in rotation. So here we can design a rotation ridge here. This is a rotation ridge on the aligner. This is the aligner insertion. It's on the T's. I'm going to show you a case. This is a case with the central incisor, malar rotation before refinement. Make sure there are malar space in the meso, distal and distal of the central incisor. And also, there is no closer contact when distal in movement. Here you can, there's space here. Let's see the, I also set up refinement design. Ten stage. From this view, you can see the last 3 stages. We have a rotation ridge designed. This is before refinement. This is after refinement. The rotation is corrected. The 5th solution for the poor correction of rotation is auxiliary elastic. As we know that the range of rotation that can be predictably corrected with clear aligner is about 35 degrees. If a rotation is more than 35 degrees, I suggest to you that correcting the rotation before taking an impression or scan for aligner treatment. This may increase the clinical predictability of the final outcome, and as well as reduce the number of aligners required for the treatment. If a rotation does not track during treatment, the following steps can be applied. You can remove the attachment so as to eliminate any unwanted interference to tooth movement. And we can bound buttons with our power chain for the rotation with button cut out on the aligner. And ensure that all the subsequent aligner given to the patient have the button cut out to accommodate the buttons and power chains. So let's see some clinical case. This case can see this is 35 rotation, more than 35 degree. As we know that the premolar derotation is a challenge for clear aligner, especially lower premolar for its round shape, even with attachment. Let's see I also set up, we can see we design a cutout in the button. This is a cutout for elastic. Please, you may find that this tooth rotation faster than Eurostaging. We have a feature called fast track or fast movement channel. When the tooth rotation is more than 35 degrees, this fast movement channel feature will be activated. The features conclude the fast movement derotation and cut out. The rotation at each stage is at least 4 times larger than Euro. That means rotate the teeth. The tooth will rotate 4 to 10 degrees at one stage. But the in the Eurostaging, the rotation is 1 to 2 degrees. So it's faster, much more faster than the Eurostaging. When the rotation is finished, there are attachments placed on the tooth. Has been rotated for retention. By the movement, the rotation of the tooth was accomplished by the elastic. So let's see in this case, we have a couple force, buccal and lingual. Buccal lingual, you can use power chain or rubber band. This can be replaced by the patient. This should be had to be placed by the doctor. This is after treatment, after the rotation of the teeth, and you can see the attachment bounded. This is after treatment. Another case, the teeth 15 rotate more than 100 degrees. Please note, this is a lingual cusp. This is the buccal cusp. So it's a rotation more than 100 degrees. So the treatment goal is that just rotate the teeth clockwise. Let's see the eye also set up, cut out, and with the rotation progress, we change the place of cutout, change the button. You can see only 20 stage we correct the very severe rotation of the premolar. At start of the treatment, progress, the rotation improved, better, and the rotation was corrected in a short time. So the summary for the poor correction of tooth rotation. The trouble, the cause, and the solution. We come to the last one about the development of posterior open bite. The transient intrusion of posterior teeth due to aligner materials on the occlusal surface. This is may occur more in patients with brachyfacial skeletal pattern and in patients who grind or clench their teeth. Some patients may report that they don't feel their back teeth touch, or you may detect a lack of posterior contact using articulating paper. So the thickness of aligner may be the cause of this very minor posterior teeth open bite. Or sometimes the bite is duct type. How to deal with this problem? We can go to nighttime wear in retention to allow the occlusion to settle. Just ask the patient to wearing the aligner at nighttime. Or we can cut the aligner distal to the canine or premolar. And if necessary, to allow the posterior teeth to erupt into occlusion. This is one of the very important options in some cases. Because there are the anterior teeth or aligned, and only there are very minor open bites in the posterior teeth. You can cut the distal part of the distal segment of the aligner and only wear the anterior segment of the aligner and let the molar erupt naturally. So it may take several months and get to the tight occlusion. This case is respond very well to aligner section. And I think the most important cause for the posterior open bite is the premature contact of anterior teeth. This is often result from the following circumstances. The first, the loss of upper anterior torque. The second, the incisor intrusion not fully expressed. And the third, the temporary premature contact of anterior teeth. Let's see one by one. For the first, the loss of upper anterior torque. How to deal with this problem? As we know that orthodontics, whether we with fixed appliances or aligners, tend to tip teeth. In cases where palatal tipping of upper anterior teeth is not desired, during upper incisor retraction, for example, we should make sure to build into adequate palatal root torque over treatment into the final occlusion in the IOS plan stage. And usually we have the over-treatment of palatal root torque by 10 to 15 degrees. And this will provide an anti-tip force, especially in the premolar extraction cases, to compensate for loss of anterior torque during we retract and to eliminate any premature incisor contact due to the loss of upper anteriors. So prevention is the most important thing to do. So build adequate palatal root torque movement. And for the incisor intrusion not fully expressed, how to deal with this problem? Also, first, the deep bite case should be overtreated to a 0 millimeter overbite in the final position of the IOS design. And the second, use our deep bite correction innovation, such as occlusal ramps. It's similar to bite ramps and intrusion attachment and intrusion ridge. This is a case for premolar extraction case at the refinement stage. You can see the extraction space have closed and teeth alignment is good, but there are mild premature contact at anterior teeth and the bite of some posterior teeth are not tight, we detected by the occlusal paper. Although you can see from the picture, it seems perfect, but in clinical examination, we found there are the posterior teeth, occlusion of posterior teeth not very tight. There are interproximal contact of lower incisors did not get tight. So this is a also refinement we can see. We design a diagram here, and also we design a extrusion of some posterior teeth and intrusion of lower incisor to tight the contact, to tight the interproximal contact. This is interview after treatment. There was no premature contact in the anterior teeth, and the posterior teeth bite very tight. Another case, there is a supernumerary tooth here. So the treatment plan, we extract these teeth and close alignment and close the space and retract upper and lower incisors to improve the protrusion of the profile. This is a IOSO setup. You can see they are IPR designed in the lower arch to create space for the retraction and the intrusion of the anterior teeth, lower anterior teeth. From this view, IPR and the intrusion of lower anterior teeth. This is a mid-treatment intraoral view. We can see there was slight open bite in the posterior teeth. There are premature contact in the anterior teeth. So we start a refinement. The lower anterior teeth intrusion and posterior teeth extrusion was also designed for the refinement. Some intrusion of some posterior teeth and intrusion of anterior teeth, lower anterior teeth. Intrusion, not so much. Open bite of posterior teeth, improved. Okay, we come to the solution. The summary of the solution of the temporary premature contact of anterior teeth. The first one, I also set up management. So this is very important. When we design, when we made the treatment plan in the stage of IOSO treatment plan stage to overcorrection of the deep bite, and also adjust the pace of upper and lower aligner changing. Let's see another case. This we can see is an edge-to-edge occlusion of anterior teeth. Let's see the IOSO setup. We extracted this premolar and the lower incisor and retract the upper and lower incisor to close the space, to close the extraction space. With the progress of the treatment, we found that posterior teeth open bite developed here. You can see both sides, and there is a premature contact incisor was detected here. This situation is similar with what we have talked about in the abnormal tooth mobility caused by occlusal interferences. The solution is also similar. We just stopped changing upper aligner and retained with the current aligner, and lower proceeded as usual until the occlusal interferences was relieved in natural occlusion. So the occlusion become better. No occlusal adjustment needed because we know it's a temporary occlusal contact, occlusal interference. This is after treatment. It's a summary of development of posterior open bite. Okay, let's make a summary for today's topic. And I plan the frequently encountered troubles and shooting. In this table, you can see the trouble, the cause, and the solution. And it will be very convenient for you to understand and remember. So today we talk about the several troubles in clear aligner treatment. First, abnormality, tooth movement. The cause, the first one is force on the teeth was too heavy. And we can solve it by the patient compliant education or dropping back aligner or reboot. Another cause is occlusal interferences was present. So we can, first, we should have a very good management in the ISO setup stage. Also, the second, wearing aligners all day long, except for brushing, to avoid the interferences during the daily life. And the third, adjust the pace of upper and lower aligner change. The second trouble is undesirable tooth protrusion. The cause is lack of space, the most important cause. So we can first, how to solve the problem? First, the setup management. I also set up management is the most important thing to do. The second, clinical monitoring. And the third, reboot is necessary. And the third trouble is the off track of tooth extruded. Also, the cause is lack of space or tooth extrusion movement too fast or attachment not designed or bounded. How to deal with this problem? For the lack of space, we can create space, IPR, and biting on choice for a mild off-track case. And also we can use assisted with auxiliary elastic to get the tooth back on track. For tooth extrusion moved too fast, we ask the technician to slow down the movement of the teeth. For the attachment, not designed or bounded. So I also design management is very important. You should design the attachment on the tooth to be extruded, and bounding attachment when it starts to extrude. And also for the teeth off track, we can use elastic to get them back so we can continue our treatment, the decided treatment plan. The fourth is about the fourth trouble is poor correction of tooth rotation. The cause is also because of the lack of space or off track of aligner. So the aligner doesn't work when it's off track. So we can create space by IPR, or we can use dimple plier to to add a force on the teeth, or we can bound a bump on the teeth, also to activate or to engage a force on the teeth. Also, we can use rotation ridge when we in the refinement stage, or we can use auxiliary elastic to correct the severe rotation that cannot be achieved or cannot be efficiently relieved by clear aligner. The last trouble is the development of posterior open bite. Yeah, it's because of the thickness of the aligner or premature contact of the anterior teeth. There are some reasons, there's some cause for the premature contact of anterior teeth. For example, the loss of upper anterior teeth stalk, incisor intrusion not fully expressed, or temporary premature contact of anterior teeth. Though we can, for the thickness of aligner, we can reduce the wearing time of aligner, only wear the aligner at night time, or we can cut the distal segment of the aligner to let the posterior teeth free eruption. For the talk, loss of the anterior teeth talk, we can add the adequate palatal root talk over treatment when we in a ISO design stage, and also we can design and 0 millimeter overbite in the final position of the ISO design, and also we can use the bite correction innovation. For the temporary premature contact of the anterior teeth, it's also important to manage this problem, to avoid this problem in the ISO setup stage. And also we can adjust the pace of upper and lower aligner changing to solve this problem.